Hello, my name is Dr. Robert Kaufmann, and we're about to go beyond the terminus. Today we're going to talk about the concept of disease versus disease that matters. The distinction may be quite subtle, but it's important in endodontics. As imaging techniques have become more and more sophisticated, we start to use CBCT imaging more and more. We're finding that many of the cases that we thought were completely healed and that had no radiolucent findings at the apices with conventional imaging do, in fact, have persistent radiolucent areas in the CBCT. And these teeth are often completely asymptomatic, and the patient is unaware of it. The tooth has been placed back into function with proper restoration and no symptoms at all. In other situations, decades-old endodontic treatment, which we would consider poorly done by today's standards, may show a persistent area of radiolucency at the apex, but again, the patient's asymptomatic. We used to use the presence of a radiolucent finding as a proxy for our discussion of whether the treatment or retreatment of the case was successful or not. Does the persistent radiolucent area indicate disease that must be treated? All of us have disease of one type or another. In many situations, that disease is subclinical or not apparent to us. We may have no symptoms from this disease. Endodontics has begun to move away from the concept of pointing to a radiograph and calling the area healed or unhealed. It's not uncommon for a general dentist to send me a radiograph with an endodontic treatment that may have been performed many years ago and that has a persistent radiolucent finding at the apex. Treatment may be either good quality or substandard on the radiograph, but the patient doesn't know the difference. Without historical films, it's impossible to determine whether the radiolucent finding has been present since the initial treatment, perhaps decades ago, or whether this is something new. Technically, the patient may have a periodontitis, as it is classically defined, that's subclinical, or what some people may regard to as persistent periapical disease. If the patient is asymptomatic and this radiolucent finding is not increasing in size, is it periapical disease that matters? Does the presence of a radiolucent finding indicate unhealed disease that justifies retreatment of the case? In years past, it was easy to point to the radiograph, tell the patient that there was a dark spot on the x-ray that indicated that they had an abscess or an infection, and that endodontic treatment or retreatment was necessary. How much better are we making a patient when we consider what is required to correct the radiographic appearance? We must consider the possible complications and liabilities of attempting to retreat cases which appear to be failing radiographically but are asymptomatic to the patient. At a TDO seminar I attended some years ago, a very famous medical researcher, Dr. Roger Lewis, commented to a group of endodontists that patients don't arrive in our offices pointing to a tooth and claiming that they have a radiolucent finding at their apex. They're in your office because they're complaining of symptoms. Whether the periapical condition is completely healed or not on a radiograph is immaterial to them. They just want relief from their problem. Are we treating to the radiograph and not to the patient? Perhaps it's time to take a more sophisticated approach where we rely upon other factors rather than just merely the radiographic appearance to decide whether treatment or retreatment of a case is necessary and whether endodontic success has been achieved in this particular case. So before you consider retreating a case or sending a case for referral, don't simply look at the radiograph. Examine the history of the case. How integral is this to the patient's dentition? Has the patient ever had symptoms associated with this area, and how frequently and recently did they occur? What would be involved in retreating this case? What would be the cost to the patient, both in financial resources and possible loss of tooth structure? What if your treatment results in loss of the tooth? Ultimately, will the patient be better off attempting to address this disease or leaving it as it is? Does your patient have disease that matters? Disease that matters to them and not just to you. Remember, when we do the right thing, we both get better, patients and clinicians. Thank you for listening. I look forward to seeing you again when we go beyond the terminus.